Well, I'd like to welcome all the attendees to this second in our seminar series on COVID-19, which we've entitled Answering the Call. And just a few housekeeping items before we get started. You do not need a microphone or a video capability to participate in this seminar. And at any point during the webinar that you want to ask a question, and you can do it anonymously, you can do it through the Q&A feature that's on the bottom of your screen. This webinar will be recorded, and a shareable link will be provided right after the event. So the title of today's webinar is Breakthroughs in Testing, and all you have to do is tune in to any network or cable channel, and that's dealing with COVID-19, which they're pretty much doing 24/7 now. And testing is front and center almost any discussion that's being had. We have three speakers today. The first one is Dr. Tim Ferris, who is a chairman and Chief Executive Officer of the Mass General Physicians Organization. Dr. Eric Rosenberg, who is Director of our Microbiology Laboratories, and Dr. Rochelle Walensky, who is Chief of our Infectious Disease Division. So as not to take any more of their time, I'm going to turn things over to Tim.
Very much, and welcome to all of you who've joined us this afternoon. It is daytime here, but I know the picture behind me is showing the white building, which was lit up in blue, which is one of the wonderful, I guess now celebrations of healthcare is lighting up buildings in blue, and we had our event just last week, so I'm pleased to have that showing behind me. My role here is really to introduce the subject and get us on the same page with a bit of factual material about where we are in the pandemic. And so with apologies for those of you who are keeping close track of what's going on. Today's the day that the US passed 1 million cases, and the world is now seeing about 3.1 million. So that means the US, of the known cases, the US has about 1/3 of the total reported cases in the world. But as we're going to discuss, case counts depend on testing, and testing varies by country. So in some ways, cases that we know of are a poor metric for prevalence. So all countries do a better job at counting deaths than testing for COVID. So maybe another way to look at this in terms of comparing worldwide prevalence is it's to look at deaths from COVID. So there have been 217,000 deaths in the world as of the most recent data from Johns Hopkins, and 58,355 deaths in the United States. So the US has seen 27% of the reported worldwide deaths. But even this is subject to some controversy because, in fact, labeling deaths as due to COVID, the practice of that not only varies from country to country, but actually varies in the United States, between one state and another state. So even that is subject to some controversy, as the press has pointed out the past couple of days. So let's look closer to home. So despite being the 15th largest state by number of people, Massachusetts has the 3rd highest number of cases at 58,000. But we've also done more testing than most states. So what about the deaths? So Massachusetts has a 0.46 deaths per 1,000 people, while New York has 1.2 deaths per 1,000 people. Massachusetts is 4th in deaths per 1,000 behind New York, New Jersey, and Connecticut. Many cities the same size as Boston have had very many fewer cases and fewer deaths. So Boston's been hit relatively hard. And Mass General has played a key role in Boston's response to the COVID epidemic. So we've admitted approximately 1,000 patients between March 10th and April 25th. That's required us to transform our hospital to basically 1/3 of all the beds in the hospital are now devoted to taking care of COVID patients. We've had at least 600 discharges to date and approximately 90 deaths. Currently, we have 302 COVID positive patients and an additional 120 that are presumed positive within our hospital. So we are still over 400 patients dedicated to this pandemic in a hospital that is 1,000 beds. COVID admissions account for less than 20% of all admissions to the hospital between March 10th and April 25th. And that's just to point out that the business of taking care of people with all kinds of illnesses continues to go on during this pandemic. And then I'll just conclude by saying that the real core of this transformation has been in ICU care, intensive care unit care, and patients on ventilators. We have currently 3 times as many intensive care unit patients in this hospital as we normally would have during normal operations. That means we've transformed 10 floors that used to be dedicated to inpatient general care or post-operative care to ICU care. That's been a extraordinary transformation. And I'll just mention one name, Catherine Hibbert, who has led the expansion of our ICUs and the care of our ICU patients in just an extraordinary way through this pandemic. So where are we now? Well, we are past our peak. I'm saying that knocking on wood. Our peak day for admissions from the emergency department was April 10th. Our peak number of ICU and ventilated patients was April 19th, so 10 days ago. And we are now, and at that time, we had 170 patients on ventilators. We're now in the 120 range, so we've had a steady drop from April 19th. And then, so we are now, because we're in this plateau, we are now in our planning phase for how we're going to manage both COVID and non-COVID patients going forward into the future. And that leads me to my transition. And it's a great pleasure to introduce Dr. Eric Rosenberg. And you have his bio, so I was told I shouldn't take up time introducing him. But I just want to say that, Eric has just been a phenomenal leader of all of the testing that goes on in our pathology department. And you're in good hands as I turn over the podium, the virtual podium to Eric. Take it away, Eric.
Thanks, Tim. And, I must say, as an infectious disease physician and as a director of a clinical micro lab, I spend most of my time behind the microscope, and this pandemic has put us right flat square under the microscope. And I know that you've all heard a lot of things on the news every day about testing. And it is one of the keys that we have to diagnosing COVID infection, as well as understanding where we are and where we're going. So what I wanted to do is spend the next few minutes demystifying all of the stuff that you've been hearing about testing and discuss the different types of tests, what these tests do, what they measure, how good are the tests, because we've heard a lot of things from they're terrible to they're so-so. And also say a few words about how these tests are being used in clinical practice and what the results mean. And then I'd like to just describe our early efforts at MGH to make these tests available to our patients and our community, and some of the challenges that we faced early on and some of the challenges that we continue to face. So currently, when I think of testing, there are really 2 buckets or 2 categories of different types of tests. The first category of test is used to directly detect the presence of the virus, which if the virus is present, it's diagnostic of having active COVID-19 infection. And what you may have heard on the news is that unfortunately, if the test is negative, it doesn't necessarily mean that you don't have it, although we think it makes it less likely. And so we'll spend a little bit more time talking about directly detecting the virus. And then I'd like to turn to the second category of testing, which is detection of antibodies, which are produced by the human body in response to infection. And so you've heard the term serologic testing or antibody testing, and those are the types of tests that fall into this category. And since antibodies are produced by the body in response to virus, these tests don't detect virus itself, but are really an indirect strategy to determine if an individual has been exposed or infected with COVID-19. So really, in order to understand testing, it's important to put it in the context of what do we know about the natural history of this infection? And I think one of the challenges that we're faced with is we are trying to figure out the natural history of COVID-19 while we're developing strategies to test for it and mitigate it and treat it. And so the first step in the natural history of any infection is transmission. And we know that virus is transmitted through secretions that are either propelled through the air when somebody coughs or sneezes and winds up in somebody else's nose or mouth, or these secretions land on surfaces. And so we know that touching surfaces and then touching our nose or our face introduces the possibility of introducing or inoculating virus into our body. So once virus reaches the nose or the upper airway, the virus is now where it wants to be, and it starts to rapidly replicate or reproduce itself. And this happens in massive quantities. And so this is precisely the first opportunity from a testing standpoint that we have to diagnose COVID-19 by directly detecting the presence of replicating virus in the nose, far back in the back of the nose, really where the nose meets the throat, and that's called the nasopharynx. And so you may have heard the term nasopharyngeal swab, which is the large Q-tip that's put all the way in the back of the nose to collect a specimen in order for us to look for the presence of virus. So after virus begins to replicate, we have the ability to detect viral genetic material or viral RNA, which is really just a genetic signature that's unique to the COVID-19 virus. And this test is commonly referred to as Pcr test or a nucleic acid test because it's designed to detect very specific genetic material from the virus. And so this is the test that you see every day where somebody drives up and a healthcare provider comes out, swabs their nose, and then they're sending that swab to a lab like ours where we are trying to amplify the presence of those nucleic acids in order to see if virus is present. This is a strategy that in a clinical micro lab, we have done every day in high volume for the last 20 years. And so the first question is, why was this such a hard thing to bring on with COVID-19? And the bottom line is that as we as in all clinical labs throughout the country have become very well versed in doing this sort of diagnostic test, we've all developed and implemented very high throughput platforms that allow us to do many tests of a specific infection at once. And one of the biggest challenges is that all of these expensive, fancy platforms and instruments that we have are very specific to companies and to a given company. And so we are reliant on company A to give us the reagents from company A to perform a test. And so what happened in the early days of COVID-19 is that a lot of these companies didn't have a test yet. And so we had a lot of very expensive and fancy laboratory equipment that we couldn't use because there weren't tests to actually put on these sophisticated instruments. So we started to encounter a lot of trouble. And the first challenge that we encountered was that the Center for Disease Control developed in Atlanta, they developed an assay for COVID-19, and they had some trouble making that assay as effective as possible. So stumbling block number one is that the CDC, who took the initial lead in developing testing, had an initial tumble coming out of the blocks. And then the second obstacle that we encountered was that the CDC went to the FDA and got emergency use approval for their assay, and all labs in the country were expected to adopt the CDC's assay because that was the one that was approved by the FDA. And so as the CDC was having trouble mass producing these reagents, a lot of laboratories, including our own, were left with no reagents and the wrong platform to try to reproduce these tests. And so in order to get a test online for clinical use, you not only have to have the appropriate instrumentation, you have to have the right reagents, and then you have to have patient specimens that are both positive for COVID as well as negative for COVID to be able to test your test and make sure that it performs the way that it should. So we initially had no access to CDC reagents because they were being shunted towards state laboratories so that the state labs can get testing up and running. We didn't have the right instruments to use the CDC test. And at that time, which was in very late February, we had no patient samples in order to validate our test. So once we realized that help really was not on its way, we decided that it's in our own best interest to develop our own MGH-based test as quickly as we could. And so we started developing a test on March 6th. And what I'm most proud of is it took the CDC over 3 weeks to develop their test. And on March 6th, we started our test, which was on a Friday evening. And that was stimulated by the fact that we learned that there was a local conference in Boston in which there was at least one person we learned whom had COVID-19. So really the first known case in Boston. So that stimulated us to start to develop a test. And we started on March 6th. And 1 week later, 7 days, we had a fully validated test and we were up and running to test for COVID-19. So we started our own in-house testing on Friday, March 13th. And one of the strengths of bringing in our own test is that we were then able to use it to enroll our first MGH patient into an NIH-funded drug study testing out the drug remdesivir, which is probably the most promising drug in clinical trial. And so we were able to enroll our first patient on Sunday, March 15th, 2 days after we went live. And then we were up and running and moving forward with our test. Unfortunately, our test at that time, because it was just a mix and match of old equipment and kind of putting together the reagents as we could, it was a very low throughput test where we were only able to test around 20 or 30 patients a day. But I think it served two good purposes. The first purpose is that we were able to diagnose the sickest patients among us. And the second purpose is that it served as a bridge so we can then start working on tests which were faster turnaround time and higher throughput. We were the first hospital in the state of Massachusetts to have a COVID-19 test. The only agency in Massachusetts that had a test before us was our state laboratory because they received the CDC test. And we were one of 3 academic health centers in the country to have our assay data evaluated and approve emergency use approval authorization by the FDA. So since that time, we've increased the throughput of our testing. We've subsequently been able to access more commercially available reagents because we have these platforms for other tests. And as of today, our current testing volume on a daily basis ranges somewhere between 500 to 600 tests per day. And that's in comparison to the Massachusetts State Lab, which has the capacity to do around 400 tests a day. And we're able to turn around results within 2 to 10 hours, depending on the specific test that we use. Interestingly, at MGH, we have the capacity to produce over 2,500 COVID-19 results a day, but we're still limited by the reagents that are allocated to us from the various companies, which are doing their best to mass produce reagents. They just can't make them fast enough to satisfy everybody's needs. So one question that always comes up is, how good is this PCR test? And we know that once a person develops symptoms, our data suggests that if the test is performed correctly, we should be able to detect virus in symptomatic patients about 90% of the time. So that means that 9 out of 10 people benefit, but 1 out of 10 infected people may be falsely negative. There are several reasons why these false negatives occur. One is that the specimen that's collected is not necessarily adequate. It's not a comfortable feeling to have this test performed. And so if somebody doesn't complain about it, it means that the test specimen itself was likely not deep enough or adequately obtained. We know the other reason for potential false negative tests is the timing of when the test is performed. Most people shed virus in their nose before they have symptoms. And paradoxically, by the time people become very ill, sometimes the virus has left the nose and is wreaking havoc somewhere else in the body. So the timing of when the test was performed, we know is critically important. So if the test is positive, we feel very comfortable with diagnosing somebody with COVID-19. If the test is negative, then it really depends. It depends on if the specimen was a good specimen. And it also depends on when in the course of somebody's natural history of disease, the test was obtained. For the first 5 days of symptoms, we think our test detects virus about 90% of the time. By day 6 to 8 of symptoms, we think we detect virus somewhere between 86% on day 6 down to 74% by day 8. And then after day 8, it's almost a coin flip where we'll be able to have about a 50% sensitivity, meaning that we'll only detect virus in about 5 out of 10 patients. So what do we do next? So that brings us to the second kind of test that we do, which is called antibody testing. And so I really think of this as a baton pass, where the first test that's useful is the PCR test, or the genetic material test. And then the second test is testing for antibodies generated by the body. So we know that regardless of what virus infects the body, it usually takes days to several weeks for the immune system to start developing antibodies against a particular virus. And one of the very first immune responses is the development of antibodies, which are these highly complex proteins that bind to virus, neutralize the virus, and then help the body eliminate that sort of antibody-virus complex. And so we know that antibodies are critical to providing immune function, but the good news is that they can also be used as a diagnostic aid, telling us, if we can detect them, that the body has been infected with a virus like COVID-19. So currently, there are 2 types of antibodies that are produced by COVID-19. One is called an IgM, and you may hear that on the news. And this is basically the first soldier that the body sends out to try to bind to virus. So IgM is a very immature antibody. It's produced quickly. It does the best it can. But then within days to several weeks after, the body will make a second type of antibody called IgG, which is a more mature, better immune response. And IgG may last for the rest of somebody's lifetime, indicating that if we could measure IgG, that you've been infected at some point in your life with COVID-19. These diagnostic assays can detect the presence of antibodies, and therefore they can aid us in determining if somebody was infected with COVID-19. We know from our studies that antibodies are detected within a few days, and in most people who have symptoms, we can detect that very first antibody, the IgM, within about a week after symptom onset, and then the IgG comes up shortly after. So a positive antibody test tells us that somebody was exposed and infected with COVID-19. It doesn't necessarily tell us when. It doesn't tell us if somebody is still infectious. And one of the biggest problems that we're facing is it doesn't, at least today, tell us whether if somebody has these antibodies, if they're immune from further infection with COVID-19. So right now, the best use of antibody is to combine it with our first test, the PCR test, if that PCR is negative, to help aid in the diagnosis of COVID-19. So what have we learned from all of this? We learned that it's really important never to go through this again, and that the lessons that we're learning in the laboratory now from this pandemic will force us to be flexible, ready, and able to respond a lot quicker in the future if we ever get into a quandary like we're in now. And on the bright side, it's offered significant opportunities for collaboration amongst investigators and physicians, academic centers, and industry to not only figure out how to provide the best test for our patients, but also how to get our hands around studying this pandemic so that we can make more sense of it. So I will stop there and I will turn it over to Rochelle for the infectious disease perspective.
Great. Thank you, Eric. What a pleasure to be here. Thank you for all of your participation. It's been incredible to work with all of the partners on this call, Tim as well as Eric. I do remember sitting in a conference room in early March with Eric saying, are we gonna sort of start working on this test, and what do we need from a clinical perspective, and how quickly can we do it? And those were some intense conversations because it was gonna require a lot of resources, and boy, am I grateful we did. You did. So maybe what I'll do is spend a few minutes picking up where Eric has left off with regard to antibody, because a lot of the questions that I have been receiving are related to herd immunity. How much do we really need to have in this population? How much antibody do we need to have in this population? How many people need to have had this disease if we could contemplate herd immunity? So herd immunity is the sort of the epidemiologic term that suggests that, that we use in vaccines, for example. And it means that if you could have enough people who are immune to the disease, then people who were vulnerable might actually be protected in some way as well, because the transmission cycles would stop. So that if somebody had disease, the next 4 people that they would bump into actually were immune, so they couldn't give the disease to somebody else. There have been estimates of herd immunity, and the first thing I should say is the herd immunity implies just that there is immunity from these antibodies. And as Eric just noted, we're not positive that that's actually the case. But there have been estimates that we would need to have somewhere between 50 and 66% of this population, of our population, with antibody in order to have herd immunity. So that's a hefty number. And I would say, wow, it feels like, certainly if you're working in a hospital, that there are a lot of people with this disease. What I can say from a population basis is we're not anywhere close to herd immunity. Herd immunity usually happens when we have big vaccination strategies, and obviously we are not there yet. There have been studies out of California that have looked at how much herd immunity is there, how much asymptomatic disease is there, because we do know that there's been a lot of asymptomatic disease, and everybody, I think, is quietly going to get their antibody test and really hoping that they had it and it was asymptomatic. I think we're all sort of wishing for that. What they found in this California study, and there were challenges with it, but what they found is that there were somewhere between 50 and 85 times the number of people who had antibody than of the disease that they detected, which is huge, like a lot more disease, or a lot more people with antibody than they knew about. So that was the good news, is maybe we're on our way, because there's been a lot of asymptomatic disease out there. The flip side of that was it only amounted to about 2 to 4% of the population. So while there was a lot more disease, it was nowhere close to what we needed for herd immunity. So maybe I'll shift now and talk a little bit about contact tracing, because I've gotten some questions around contact tracing. So first of all, what is contact tracing? So In epidemiologic terms, during a pandemic, we move from strategies that are called containment strategies to strategies called mitigation strategies. So the mitigation strategies are the really inconvenient ones, the ones we are living right now. They are no travel, hand washing, masks, stay-at-home orders, all of those really blunt tools that we are using because we are trying to stop contact to transmit the virus. And we've moved from to mitigation, and what we really want to do is move back to a strategy of containment. So strategies of containment are when we believe testing is so available that we can test every person who we think might have disease. We can identify that person really quickly and then isolate them and then find out all the people they have been in contact with. And in this case, we call contact less than 6 feet away for more than 10 minutes of time. So if you could recall anybody in the 48 hours prior to an event, a test, that you had been in contact with for more than 10 minutes at less than 6 feet. That's what we're talking about contact tracing. If we could isolate people who had the disease and contact trace all of their contacts, then we could potentially quarantine them and again stop the disease transmission. We do this all the time for measles. So there's so little measles in our population that when we have a case of measles, and I've seen 2 in my career, all the contact tracers in Department of Public Health come out, they appear in the hospital, they show up, they find out where this person has been and every person that they've been in contact with, and they go contact trace them. It's an enormously burdensome event, but we can do it when we have small numbers of cases. And so that's why once we've gone from containment to mitigation, where we have large numbers of cases, contact tracing becomes really impossible. We don't have the manpower. But if we could potentially move from our current strategy back to containment, meaning fewer cases, the capacity to contact trace, we have the capacity to actually get this epidemic under control. And testing is certainly a major key to that. The last piece I want to really talk about is what does it take to get from mitigation, these blunt tools, back to containment? And really, I think what that question means in English is, how do I get back to work? How do I get my life back, right? That's what everybody has been asking. What do we really need to quote unquote reopen, or I will term it recover, because I will say in the hospital level, we've been open, right? A few things I think need to happen. One is as much as we are traversing through this plateau, we're not at normal capacity yet. We're not at normal levels yet. We still have a lot of people working in functions that aren't what they usually do. You might have seen our chief of orthopedics being a scribe in our clinic in the Boston Globe. We're not in normal capacity yet. And we really want to make sure that the message is our hospital is open for regular business. We can take on surgeries. We can take on elective surgeries. We can take on all of the things that we would normally take on. And we're not there yet. And so I think the hospitals are a key barometer for how we're doing as a society, and not just our hospital, but I think really any hospital. When we open, I think we need to first of all, I do believe that our next 6 months to a year, we're going to all be wearing masks for a while. It's very hard we've been doing this in the hospital, it's very hard to recognize people in masks, actually. And it's really not particularly social, fun, or comfortable, but I would say I think that that's going to be one of the mitigation strategies we're stuck with for a while. I think we need to decrease our density and think about strategies for how people can work in shifts, whether they work for a week and then return home for a week and have the other half shift work the next week. But I do think we have learned how to function pretty well in this new way that we've been living for the last month or so. And I do think that we are going to have to maintain some decreases in density, either on the T or in work or in our hospitals or in schools in some way. I think we need to set the table with the fact that we need to be prepared for the logistical, financial, and emotional truth that we may have to do this again. And that's a tough pill to swallow. But I do think that if we use, again, the hospital as a barometer and we start seeing that our ICUs are full, that might be a time to sort of reclose. And folks have talked about intermittent reclosures, but I don't think we ever want to experience the peaks that we had in this last month, the deaths that we had in this last month. And so I really think that that's going to be a key point of what we need to recognize. They should be shorter, they should be less painful. But as I think about what could potentially happen in flu season next year, I could see that we will be doing this again. I think many have written about, talked about, you just heard about from Eric, what we need to do with testing. I think we do need to have lots of testing if we are going to move from containment back to mitigation, from mitigation back to containment. But in my mind, testing isn't enough. I think we need to understand what the results of those tests are. We need to act on them quickly. We need to contact, trace, and find people. There have been published reports that isolation and contact tracing all has to happen within 24 hours in order to stop the transmission in an effective way. So that's a tall order to contact trace everybody that quickly. The other thing I really want to make sure is understood is how we handle this epidemic, this pandemic, is very much going to be related to how we treat our vulnerable population. Right now, testing is voluntary. It should be voluntary. People call asking for tests. If you take a vulnerable person who would lose his job and his livelihood and his home, if he were positive and tested positive and was told he had to isolate and couldn't work, those folks aren't going to come forward for testing. And so our testing plan has to really think carefully about how we're going to treat vulnerable populations. In truth, I heard it said that isolation and quarantine is a privilege. We get to have different bathrooms if we want to isolate and quarantine, and not everyone does. So how we handle that, our T workers are not going to come forward with their coughs if they know that a test means they're going to be out of a job. And I think that that's really important to convey. And then finally, I do want to also mention and sick leave policies. We really do need to have very liberal sick leave policies if we are going to ensure that people don't come to work sick. Every runny nose in the hospital now buys yourself a COVID test. So I have had one myself. I will agree with Eric, they are not fun. And I had really mild symptoms, but right now we have to have people coming forward with really mild symptoms. Mine was negative, but you have to have people coming forward with really mild symptoms so that you can find all the disease. Maybe I'll close with just a comment about getting back to normal. I haven't been using that word, but part of it is, I don't think we're going to get back to the normal we once knew, but I do think that there are opportunities to get back to a different normal, and some of it might be a better normal. We've learned a lot through technology. I can dial on my Zoom now in my sleep, where I used to need my teenage kids to help me out. We've connected in ways that I think we previously hadn't connected. We've communicated with our elderly in ways. We've really been caring for them in ways that we previously hadn't before. With old college friends, old roommates, we've mobilized technology in really interesting ways. There are now thermometers that can go to a central place, and you can see where in the country people have spiked temps, and maybe that would be an indicator as to where the outbreak is going to be next. So really incredible ways that we've taken this unfortunate time and mobilized it into something that could potentially be better. And then finally, what I will say is this has been a slog of a 2 months. There's no question about it. But there has never been a prouder time to be in medicine, I'll say in infectious disease and at MGH, than I have been in my entire career. And I will venture that people even older than I am would say that as well. And I would say, we are tired. There's no question we are tired, but we are strong. The esprit de corps is amazing. People who I know are just on all night, when I ask for something, will come and offer more time and give. And it's just been an incredible thing to watch how the medical community in all flavors has come together during this pandemic. Thank you.
Great. Rochelle, thank you so much, and Eric, that was a terrific tour. And maybe I'll summarize a couple of things that I heard. one is that so there's two types of tests. One for the virus, the PCR traces the DNA fragments that detect the virus, and then there are the antibody tests. And that is going to be, those two tests are going to be with us for the foreseeable future as part of the armamentarium of how we manage this. What I also heard was that there is the post-COVID normal will not be the same as the pre-COVID normal. There will be changes widespread throughout our society that decrease the likelihood of transmission, so that we can have economic activity, but in a way that reduces the likelihood of asymptomatic or symptomatic transmission of disease between people. And that's going to make our social interactions different. And the prospect of wearing masks, as I've been doing, as with everyone at MGH for the past couple of months, it really does change the atmosphere of a social interaction to be wearing a mask. And that's going to take some getting used to. The other thing I heard was that we're going to have, in addition to people going about their new normal, there are going to be special populations, and what the British call them shielded populations. And these are people who are at particularly high risk, immunocompromised, elderly, who we will need to take additional precautions beyond what we're doing sort of for the general population. And so thinking about how we identify and know someone is part of one of those protected populations raises all kinds of questions, because that's currently information people walk around and don't wear a sign that says, I'm immune compromised. But in the future world, actually, there may be need for that kind of transmission of information. And what are the implications of that for our society? And then the final thing that I wanted to leave you with is just what is happening at MGH as a result of this. So we are deep into planning around what MGH looks like in the world where it's not, I shouldn't say post-COVID, COVID's still around, but we're going to live in a hybrid world where we're treating COVID and doing much more of the treatments of other things. And one thing that I wanted to leave you with, very important, is MGH is open for business. And we are open for the business of all healthcare, not just COVID healthcare. It's very important for you to understand that, because we've learned, and this is true of all pandemics, but we're experiencing it, we're relearning it in this case, but too many people are staying away from their physicians and other healthcare providers, and actually suffering consequences from that because they're staying away, because they're afraid of interacting in the healthcare world, because they think, well, we might be exposed to COVID. What I want to leave you with is that the processes and structures that we have in place and continue to build are making it safe for anyone to receive care within our organization. And that's true across the country for healthcare. It's a very important message to get out there. And we're going to be doing a lot more of messaging that, because we have some real concerns. We're noticing that people are ignoring symptoms of, for example, heart attacks and strokes. That's not the right response. And you'll be hearing much more about that if you haven't already in public service announcements. So with that, I think I'll turn it over to Britt, and Britt is going to ask us some questions. Well, Britt, we can't hear you yet.
So,
okay.
So first one, we've got a number of good questions that have come in from the audience. I'm going to turn to you, Rochelle, for the first one. This one is, with the encouraging news today released by Gilead concerning remdesivir trial and Dr. Fauci underscoring the good news, my question is, If all this proves out to be desired data and safety outcome for this drug, when would be the approximately earliest it would be approved by the FDA and deployed wide scale is needed for patients in the US?
That is a great question. So maybe I will just take a few seconds to mention there were two studies that were preliminary results were released on today. One was an uncontrolled study of 5 days versus 10 days for remdesivir. And that demonstrated that 5 days was probably enough. They looked at time to discharge, and that looked like 5 days was probably enough. So that's good news. The other randomized controlled trial that was funded, that was out of NIH, was a 1,000 person study where they looked at about 460 patients, and they were able to demonstrate that the time to being discharged from the hospital in just half of them, so they haven't looked at all of it, and just half of them was shorter in those who got remdesivir than in those who didn't. So 11 days versus 15 days. So a meaningful outcome. The second study, they still have a lot of work to do. They haven't released the results of the second 500 patients. They enrolled a spectrum of people with disease, people who were relatively well, all the way to people who were quite sick in the ICU. So there's some sub-studies that are going to be done. But overall, I think this was really encouraging. I just heard that the FDA is probably going to give emergency authorization for it. Remember, unlike some of these other drugs, remdesivir is not FDA approved for anything. So it's not even being made, that you can't just buy it off the shelf. So I think it will be quite quick. I think it'll be quite quick.
Okay. So Eric, this one's for you. If presence of antibodies does not confer immunity, doesn't that suggest that vaccines are likely to be of limited value? Secondly, given the seemingly large prevalence of asymptomatic cases which allow the virus to circulate silently, is test and trace a viable containment strategy? Finally, do you think we are likely to achieve herd immunity before a vaccine is available? So
there's a lot to unpack there, but
and you have 60
start
seconds.
with the first question, because I think right now that's probably the most difficult to answer, is does the presence of antibody correlate to immune protection? In other words, if you have antibody, does that mean that you're immune? And the answer is that we would like to think it does, but we just don't know yet. And those studies just people have not had enough time to do that kind of study. So even though it may mean you're protected, we simply don't know. And therefore, we're not able to use antibody studies to say, oh, you're antibody positive, so you can go back to work. Or we can't tell healthcare workers, you're antibody positive, so you don't need a mask anymore. We just don't have enough information to make those conclusions yet. But I think we're all keeping our fingers crossed that these tests will, tell us that you have protective immunity. We're just not there yet. The second question, as I remember it, is will we have enough herd immunity before we have a vaccine? And I'd love to hear Rochelle's thoughts, but I think that if we're all socially distancing and isolating and limiting we're trying to mitigate and contain, we probably won't reach numbers for herd immunity before a vaccine. And on one hand, I hope we don't, because that means that we're doing a good job at containing infection. And then I have to be honest, I forgot the third question.
Let me see if I can find it. Okay. I think it actually disappeared from my screen, so we'll leave that for another one. Okay. How accurate is testing for asymptomatic people?
We don't know. And the reason is that we haven't done enough testing in the asymptomatic population because we simply don't have enough tests to do it. I think it's a critical question and we need to be able to do that. But right now, all of our resources are really being allocated towards making the diagnosis in symptomatic people. I do know that small studies have been done where people have stood out on street corners in various towns in Massachusetts and have have been able to detect high rates of infection in asymptomatic people, but we don't have enough numbers and data to really make firm conclusions.
Rochelle, this one's for you. It's what is the role of vaccines and what is the likely timeline to vaccines?
Right, so vaccines will sort of help us get to herd immunity, right? So I think we are going to be living in this not so great space until we have a vaccine that we can roll out, because I think we will be worried about lots of infection and lots of people in our vulnerable populations and our immunocompromised populations. So I do think vaccines will be a game changer here. Certainly if there's a treatment that is good, that would help as well. But I think vaccines are probably going to be a game changer. I will take my lead from Tony Fauci, who sort of said about 18 months was the timeline about 2 months ago. I think that that's probably correct. There's at least 5 or 6 different mechanisms that I've seen for vaccines. News just came out 2 days ago that Oxford actually has a vaccine that's got a lead, kind of a head start. So this group at Oxford was working on a different coronavirus vaccine for MERS and was able to jumpstart sort of phase 1 and really sort of rapidly enroll. And so if that were the case, they are claiming they could have something potentially by September or October, and that they have the capacity to scale up quickly. So a couple of things to note. First is there's this, you don't know what to wish for, not that it's in our control, but if you really want less disease out there, right? We all want to have less disease out there. The problem is you don't get a good vaccine efficacy trial if you don't have much disease out there. You need the disease to show the endpoints in a vaccine efficacy trial. So it is a little bit of a catch-22. We don't know what to wish for. And then the other thing is, I think there are 5 or 6 candidates that are in trials right now or scaling up to phase 1. I'm in my prior life before COVID, I did HIV work. And so I've been burned before in wishing and hoping there was going to be an HIV vaccine. And so I just want to be cautious in my optimism, because while we do have quite a few candidates, we're not exactly sure which, if any, will be successful.
Sort of a follow-up to that, Rochelle, is that when all is said and done, do you think we'll be ending up with one vaccine or actually multiple vaccines to choose from?
Oh boy, I sure hope it would be the latter, but I'll take any single one of them.
Okay, all right. So the question that I did discover sort of the third question, and again, Rochelle, I'm going to kick this one back to you. It said, given the seemingly large prevalence of asymptomatic cases, which allow the virus to circulate silently, is test and trace really a viable containment strategy?
Yeah, it's a really good question. Maybe not, right? But I do think, I was just on a call this morning, like I can't imagine a time, and maybe Eric will think I'm crazy here, but we check sugars on people with diabetes 4 times a day at home, like really rapid, really, now it's not a blood test, I recognize it, but the testing technology can really take off. If you could test every student in a classroom in a pooled sample every day, you could potentially see if a whole school, anybody in the school had disease in a single day, right? And I can imagine that we could be in a place that was possible. You could resolve the pools, find anybody who is positive. So I do think it's not beyond possible.
Okay. So Tim, this one's for you. It's given your vantage point, but looking at the hospital as a whole, and actually the healthcare system as a whole, this was a tough one. What does normal look like, and what do you think the timeline is going to be?
It is a tough one. I think I can answer the what does normal look like better than I can answer the timeline, because I wish I had the answer to the timeline. But let me first start by saying that I am congenitally optimistic. And so anything that I say must be taken with that in mind. So I think normal is going to be a lot like what Rochelle described. I think we are going to work to, I don't think this is a word, at least not yet, but de-densify everything we do. And that means that any situation in which people gather, you can imagine we are going to need to have more space, more physical space between them. We are going to be wearing masks for the next year. throughout the world. We're going to be wearing masks for the next year. We are going to be experiencing, we're going to get used to being asked about symptoms frequently through apps on our phones. And we're going to be doing a huge increase in the fraction of people who are working will be working from home. One of the most challenging areas is going to be school and kids, because adults can work from home, graduate students can more or less work from home, but the younger you get, the more difficult it is to imagine a situation in which you had successful supervision of children, and how do parents go to work if you can't have congregate settings for kids. I think that's one of the major things that has yet to be resolved in this. So I think I've described a little bit of what life will look like. Here's sort of the optimistic approach. There are some mathematical modelers, biophysicists at BU and some at Stanford, who would say that the attack rate in various countries who have different levels of social distancing doesn't depend on the degree to which you implement draconian measures. Basically, mathematical models that say, for example, that good hand hygiene and a mask on everyone is going to sufficiently dampen the person-to-person transmission to allow significant reopening. We will know in 4 months if that is the case, because we're about to conduct that experiment. So the optimistic view is in 4 months, after doing the amount of de-densification and masking and all those things, we will know if does it come roaring back or not. I'm going to keep my fingers crossed and say we will learn in the next 4 months that what measures are necessary to bring us back into an environment of work and school and social life that we're more familiar with. Not that we're entirely, it will be different even then, but I think in 4 months we will know a lot more about how this COVID pandemic is going to play out in this next phase.
Okay. So Eric, I think we've got time for one more question, and this is another really interesting. What's the status of the direct consumer test market? What are the challenges?
So I think that the challenges to providing tests directly to consumers are making sure that the specimen is appropriately obtained. And there are a lot of different types of specimens. So for example, direct to market may include just an oral swab rather than a deep swab in the nose. It might be saliva. So obtaining a good specimen is going to be key. And then how easy it is to determine whether the result is positive or negative. And so sometimes these tests may look like almost like pregnancy tests. And how faint is the band? Is it easy to tell positive or negative? So those will be some of the challenges that we know of.
So Tim, I'm going to turn it back over to you for closing remarks. But before I do, again, thank very much to all three of our panelists. This has been incredibly informative.
Well, I want to thank you, Brad, and thank you for organizing this. It's a pleasure for us. I'll speak for Rochelle and Eric and thank them as well. So I would like to thank our audience for attending this event, and more importantly, thank you for your support of MGH. The team here benefits immensely, relies on your support, and I can't tell you how important it is to the spirit of the people who work here to learn about through our phones or through whatever social medium about all the support that's coming in. And finally, that we remain committed to do all we can for those patients right in front of us as we continue to diligently search for therapies and vaccines, and that will put this pandemic behind us. So thank you all very much for joining us for this webinar.
Thank you.
Thanks.